জি জি স্যার লাইভ শুরু হয়ে গেছে
আমি শুরু করব।
জি জি স্যার ভিডিও চলে আসছে
চলে আসছে।
জি
ওকে, welcome all to this class. It's an online class. This is the first experience for me for in this episode. I'm Aminur Rahman. Today I'm going to take your class as a topic is management of stroke. First of all, we'll go for the learning object. What we want to learn to this lecture? So our object is that definition, first a definition of stroke, then classification of stroke, then epidemiology of stroke, pathology, clinical presentation, diagnosis, and type treatment according to type of stroke, and prevention of stroke, and rehabilitation and conclusion. So it's a big chapter. As you were a fifth year student. So we are going to be short uh, for this lecture. So this lecture is very important in the undergraduate as well as postgraduate student. And so in here, for your kind information, I have written two books for you. One is Neuroimaging Clinical Practice and Short Case in Clinical Neurology. Maybe this is the first neurology books in our country. And so now we're going for the definition of stroke. So if you want to understand what is stroke, so first you have to go for the definition. And definition leads to the diagnosis of stroke. That is a sudden onset of clinical symptoms and or sign or focal at the times of global disturbance of cellular dysfunction with symptom lasting more than 24 hours or leading to death with no apparent cause other than the vascular origin. So for the definition, if we go for the remembering this point for diagnosis that is stroke, this is a clinical syndrome occurring due to sudden cellular dysfunction. Any symptom that must be sudden onset, and that produce this subheadings like that, producing focal or global neurological deficit. Focal means this weakness of one side or any specific part of the brain. There is a dysfunction, and global means there's loss of consciousness. The sudden the patient's symptoms presents as a sudden loss of consciousness. And second point, it must be vascular in origin. Any cerebral dysfunction, if it is traumatic, it needs not if it is infectious, it's not. If it is infectious but in sudden onset, it not be stroke. So it must be vascular in origin. Third point, non-epileptic, non-traumatic in nature. So must remember, epilepsy it may be sudden cerebral dysfunction, but it is not stroke. Trauma, it can causes the sudden cerebral dysfunction, but it is not a stroke. So non-epileptic, non-traumatic in origin and persist in more than 24 hours, or patient dies within this period. If the patient dies within the 24 hours with the sudden onset of cerebral dysfunction, and that is vascular in origin, and that must be focal or global neurological deficit, and it is not is non-epileptic, non-traumatic in nature. So for the diagnosis of stroke, you have to remember that it must be sudden onset, cellular dysfunction. It must be focal or global neurological deficit. It must be vascular in origin. It must be non-epileptic, non-traumatic in nature, and persisting more than 24 hours, or patient dies within this period. So from the definition, so it must if you understand this definition, so you must after that you can diagnose the stroke. What are the some common terms used in the stroke? Acute stroke is equal to brain attack. Sometimes people say that heart stroke. some heart stroke means this is the stroke of this is misnomer term, and they think that heart stroke means heart attack. So we think the acute stroke means brain attack, and every minute matter. This time is brain. So always remember this point. When I go for the treatment purpose, I will repeat this word again. Repeat this sentence. Time is brain. Time is brain. And what sometimes I will in some doctors they some medical personals they use this cerebrovascular disease CVD. It is totally absolute now because all form of vascular disease affecting the brain may be stroke, maybe TIA, maybe multi-infarct dementia, maybe AVM, maybe aneurysm, etc. So all the cerebrovascular disease leads to maybe stroke, TIA, multi-infarct, or AVM or aneurysm. So it is a misnomer term. So we do not use this cerebrovascular disease now. As you are doctor of the new century, so you must understand. Never you must remember that never use this term cerebrovascular disease as as understood by the other people that is stroke. Stroke is quite different. Stroke is always in the affecting the sudden vascular disease in the brain. It not maybe AVM, not maybe aneurysm. It not a stroke. And sometimes you will find this word CVA, cerebrovascular accident, is same as accident. So cerebrovascular same as stroke. Apoplexy is same as stroke. Terms related to stroke, another is TIA. You heard this. You already heard this term, the TIA, transient ischemic attack, brief, reversible, focal, non-convulsive ischemic neurologic dysfunction, lasting less than 24 hours. Typically, the neurologic signs and symptoms last not only for 5 to 10 minutes, 5 to 15 minutes, but definition must be last less than 24 hours. Major risk factor of developing stroke, and 13-fold increase the risk of stroke in the next year. And causes are similar to all causes of stroke. TIA may be arise from the emboli to the brain or from the from in situ thrombus from the intercerebral intercerebral vessels, that is internal carotid artery, any carotid artery, whatever in the part of the cerebrovascular of the brain. Cerebrovascular disease, I have already I already told this. All form of vascular disease that affect in the brain. It may be stroke, it may be TIA, it may be multi-infarct, it may be aneurysm, it may be AVM, etc. Complete stroke, if the focal deficit persists and not origin, is called a complete stroke. Evolving stroke, if the focal deficit continues to origin after the 6 hours from the onset, is called the evolving stroke. That is stroke in evolution. This is stroke. It may be after sometimes after within the 24 hours, it may be stable. Now, it is important what is the classification of stroke. So classification is the classification of stroke, but usually as you were in the undergraduate student, you must have this common term, this clinical stroke and the pathological clinical classification and pathological classification. Clinical classification, there's a complete stroke, no further progression, and an evolving stroke is the further progression over hours to days. And pathological classification is ischemic stroke and then hemorrhagic stroke. Another classification is arterial stroke and the venous stroke. So if we see in this way, is this source from your textbooks, Davidson? There's like the stroke classification. Stroke is maybe vascular, according to vascular origin. It may be the arterial, it may be the venous. According to pathological classification, it may be infarct and then hemorrhage. And according to the site of lesion, anterior circulation, posterior circulation. And clinical classification in the ischemic stroke, total anterior circulation stroke, partial anterior circulation stroke, Laconic stroke, and posterior circulation, vertebral basilar stroke, posterior circulation stroke. And in case of hemorrhagic stroke, it may be the brain hemorrhage, it's the intercerebral hemorrhage, and then the subarachnoid hemorrhage. So, and venous stroke is usually is the infarct, and of it may be hemorrhagic. It's in fact it usually affects the venous system, the cerebral venous sinus thrombosis. What about the sites? That will be called the superior cerebral venous sinus thrombosis, inferior cerebral venous sinus thrombosis, sagittal superior sagittal sinus venous sinus thrombosis, like that. And what are the common pathophysiology about the stroke? Is the if it is the infarct, it may be the embolus and the thrombus in situ, and this total circulation and total partial anterior circulation. It may be called that embolism and thrombosis in situ. And Laconic stroke, it only in the thrombosis in situ. And in posterior circulation mainly is affecting the thrombosis or embolism. And hemorrhagic stroke is, you say, there's the intercerebral hemorrhage. It may be the vascular degeneration, aneurysm, rupture aneurysm. It may be the rupture arteriovenous malformation. And subarachnoid hemorrhage is a rupture aneurysm, arteriovenous malformation, vascular degeneration. And venous stroke, it may only causes the thrombosis in situ. I will tell you all the causes later on in the details. What are the epidemiology of stroke? And incidence is 180 to 3,000 per 100,000 population in the world, and prevalence is 600 per 1,000 population, of which 130 is severely disabled. That is, after the people are suffering from stroke, most of the 1/3 of people are severely disabled after the people have a stroke. And it is the commonest neurological disorder in the adult life, and 50% neurological diseases among adults admitted in the patient in general ward, and it is the second commonest causes of death after the age of 40. What are the first commonest cause of death after the age of 40? It is the heart attack, or it is the cardiovascular cardiac disease, this acute MI, like that. And what are the incidence? Epidemiology in Bangladesh is 2.55 per 1,000 population. It's a recent study done by our neurologist in the country. What are the in case of ischemic stroke? What are the risk factors? You already heard these common terms in several way in the pathology and also in the community medicine. So I will not go for in the details in here. The age is usually after the age of 55 years. The risk is double. Gender, male is more than the female, and very young, except in the very young and very old. And race is more common in the Afro-Caribbean, then Asian, then European. Hereditary, the relative risk is 2.44 parental history, and relative risk is 1.4 maternal history. And previous vascular event, microinfarction, stroke, and peripheral embolism, high fibrinogen level. These are all the non-modifiable in both sexes. What are the modifiable risk factor? High blood pressure, heart disease, atrial fibrillation, heart failure, endocarditis, diabetes mellitus, hyperlipidemia, smoking, excessive alcohol consumption, polycythemia, oral contraceptive, and social deprivation. These you must memorize. There is no need to understand this one, because if you don't forget these terms, you cannot write in this here. So it must be memorized, this one, modifiable risk factor. And what are the common other risk factors, especially common risk factor in the women? Lifetime risk factor is 20%. All of the cerebrovascular accident or vascular disease is around 40%. And before menopause, pregnancy, oral contraceptive pill, and toxemia of pregnancy. And after menopause, increased hypertension, atrial fibrillation, increased low density lipoprotein, abdominal obesity, insulin resistance, decreased HDL level, and physical inactivity, taking hormone replacement therapy, and stress. What are the important points in regard to cerebral circulation? Is the usually brain weight is 2 to 3% of total body weight, but 80% of total blood circulation goes to the brain. So there is a high flow of blood supply in the brain. It's the 55 milliliter per 100 gram brain tissue per minute. So if this flow is going to if this flow is reducted, or if the flow is flow is somehow hampered, or somehow the flow is obstructed, then there will be there is the symptoms of cerebral dysfunction is arises. That is, ischemia occurs less than 20 ml per 100 gram per minute. Infarction, this is the totally irreversible damage of brain tissue is less than 10 ml per 100 gram per minute. Cell death occurs if the less than 10 ml per 100 gram per minute persists more than 3 minutes. So another term is ischemic penumbra. It is the salvageable tissue. That is the tissue may be reversible. This is a reversible ischemic changes in the brain. This is the cerebral blood flow is between the 12 to 23 ml per 100 gram per minute. Reduction of temperature by 2 to 3 degree reduce the metabolic requirement and increase the tolerance to the hypoxia by 25 to 30%. In here, there is the pictures. You can find this picture in the Davidson also, and all other neurology book also. It's the normal blood supplies above 50. This is 55 ml per 100 gram per minute. So if this blood supply is reduced up to 20, there may be brain can be tolerant. After that, there is a failure of electrical function. That's produce the symptoms. And below 10, there is the irreversible damage. There is the other ionic pump and potassium influx, sodium influx, and calcium influx causes the cell death. In here, there is a picture. You say there is a red area in here, and in behind there is a little bit violet area, and this is the totally damage of the brain tissue, and this is the partially salvageable. Salvageable means it may be reversible part of the brain tissue. That is called the ischemic penumbra. So for as I am neurologist and other neurologists in the world, all the neurologists are treating the ischemic penumbra and save the life of the people, because if we save this ischemic penumbra by any so many means of ways of treatment, so it will improve the his the disability, patient's disability. It will improve the patient disability very pronouncedly. And if this ischemic core is more, and after sometimes in here ischemic penumbra usually last in the anterior circulation we'll think that 4.5 hours, and posterior circulation we'll think that 6 hours. So if this ischemic penumbra, if you treat this ischemic penumbra within this period 4.5 to 6 hours, and it will causes reperfusion. It will improve this cellular brain cell function, and it will improve this disability of the patient's outcome. In this slide, you will find the process of neural ischemia and infarction. In here, you will find there is a different steps. First, when there is oxygen supply is decreased, there is anaerobic glycolysis. When there is anaerobic glycolysis, there is a reduced ATP production, and the hydrogen ion production is more. And this causes this decreased ATP causes ionic failure. This is the sodium ATPase pump failure. This when there is ATP pump is failure, more influx of the sodium. So in influx of sodium with associated with the water also. There is a cellular swelling. So you will after that, and there is the cell and membrane depolarization and calcium. After membrane, this membrane is depolarized, and this the calcium is entry from the outside the glutamate, and there is the NMD received to the brain cell, and this neuron. And if the calcium is entering the more, there is the intercellular the lysis enzymes. That is the lysis enzyme is activated. There's a lipid peroxidase, protease, nitrogen synthase, all are activated, and this causes and causes release of this causes the release of free radicals. In here you will see that there is the free radical, and free radicals. These free radicals ultimately activates the the thromboxane and prostaglandin pathway, and it also causes the hampering of the blood flow, the more hampering the blood flow. And in here you see glial cell take uptake of hydrogen ion. Glial cell is the uptake of the hydrogen ion. This glial cell uptake of the hydrogen ion no longer taking the extracellular glutamate, and this potassium is potassium is influx in the glial cell, and also there is a necrosis in the liquefied necrosis in the arterial whole territory. So this process is all about in the pathological process. You have already learned from your fourth year knowledge in the pathology in the cell injury. And another step, what is the pathology? Pathology in atherosclerotic plaque. So in case of ischemic stroke, there is a common term, the atherosclerotic plaque. How the atherosclerotic plaque, all the things is like falling the blood vessel intimal layer is damaged. When the blood vessel intimal layer is damaged, intimal cell, smooth muscle cell with leaden and cholesterol, lipids, phospholipids, collagen, and elastic fibers, all are forming a plaque. And this plaque may be stable, may be unstable. When there is a stable plaque is formed, it is more better. When there is unstable is formed, it is more ulcerated, or when there is a unstable form, there is ulcerated plaque, it is very dangerous to the people, to this person. The hemorrhage may become in the plaque, or plaque may be ulcerated in the lumen, in the blood vessel, forming the interluminal mural thrombus. And lumen of the whole of the blood vessel is narrowed and astonished and blocked. And plaque may be ruptured to form the emboli and occlude to the lumen and the distal vessel. So, what are the pathological type of stroke? So, there's a ischemic stroke, and another is hemorrhagic stroke. Ischemic stroke is around 85%. In ischemia, there is another subtype, is the atherothrombotic, is 52%. Atherothrombotic stroke is the Laconic stroke and large vessel stroke. Laconic stroke due to the lipohydrosis of small vessel. At the large vessel stroke, atherosclerosis of intercerebral arteries and hypercoagulability stage. And embolic stroke may be the cardioembolic and artery to artery. Embolic stroke is around 33%, and causes with the microartery infarction, valvular heart disease, dilated cardiomyopathy, mural thrombosis, atrial fibrillation, coronary heart disease, and artery to artery aortic, carotid, and intracranial atherosclerosis. And another cause is cryptic. So cryptic, there is a cause is unknown, and others. And regarding the hemorrhagic stroke, ICH and subarachnoid hemorrhage. ICH is around the 10% and subarachnoid around the 5%. And ICH causes due to the hypertension, AVM, amyloid angiopathy, and subarachnoid hemorrhage, rupture aneurysm, AVM, and ICH. So a specific risk factor for the intercerebral hemorrhage, that is the hypertension, 40 to 50% is commonest. Amyloid angiopathy is the next commonest. So in case of this two things is interchangeable. If the patient is young age, the hypertension is the main cause of the interstitial hemorrhage. If the patient is old age, amyloid angiopathy is the one of the important causes, then the hypertension. Because in the old age, there is the amyloid deposition in the blood vessel. Blood vessel may be the it's going to be hardened, and if the pressure is increased in the brain, somehow increases, there is a more rupture in the amyloid vasculopathy. And another is avian, aneurysm, neoplasm, anticoagulant, vasculitis, drug abuse, idiopathic, and age 40 to 60 years. Women, important cause hypertension and vasculitis. And causes interstitial hemorrhage and the associated risk factor. That is the small vessel disease with the with this distal disruption of blood vessel, age and hypertension, amyloid angiopathy, familial and age, impaired blood clotting and anticoagulant therapy, blood dyscheresis, thrombolytic therapy, muscular anomaly, arteriovenous malformation, and cavernous and hemangioma. Substance misuse is alcohol, amphetamine, cocaine. And risk factor of subarachnoid hemorrhage is the rupture baryon. That is, baryon it is usually is a bifurcation of the major intercerebral vasculature, and the vertebral basilar arterial system. This baryon is a 7 to 75%, AVM 5%. Other causes of the brain disorder, anticoagulant, vasculitis, undefined age, and female is like that. Undefined age is 15%. And for women, is the important cause is the vasculitis. And causes of young stroke, in case of ischemic stroke, cardiac embolism, premature atherosclerosis, arterial dissection, thrombophilia, homocystinuria, phospholipid antibody syndrome, systemic lupus SLE, vasculitis, CADASIL, mitochondrial cytopathy, neurovascular syphilis. And causes of primary ICS in case of young stroke is the arteriovenous malformation, drug misuse, coagulopathy. And subarachnoid hemorrhage, saccular baryon, AVM, and vertebral dissection. What is the clinical presentation of ischemic stroke? So you must remember, and you must, this is a warning sign of stroke. You must circulate this. You must give the information to your general people, your parents, your neighbors, your friends, like that. Be first. Easy to remember. Be first means B for balance, the loss of balance. If this sudden onset of cerebral dysfunction, the loss of balance or dizziness, we must think it may be stroke. Eye, there's the eye symptom, sudden visual loss, one or both loss. Sometimes the term that amaurosis fibers. And face, does one side of face is droop. Arms, if one arm is weak or numb. Speech, if the speech is slurred. Time is very critical. Time means brain. So we'll tell you this, what is the time, why time is very much important. And how can you assess, how can you rapidly assess in the stroke in the emergency room? This this what is the Rozier scale, the recognition of stroke in the emergency Rozier scale, recognition of stroke in emergency room. This Rozier scale. Rozier scale is the unital face weakness, unital grip weakness, unital arm weakness, unital leg weakness, speech loss, visual field loss. All the is 6 point. This was 6 point. Another two important point: loss of consciousness and seizure. Loss of consciousness. There is so many causes of loss of consciousness. So loss of consciousness. If the patient comes to you, loss of consciousness, it may be -1. And seizure, if the patient comes to you seizure, it may be -1. So total score is -2 to +6. If the score more than 0, or is more than 1 or above, indicate the stroke is possible cause, excluding the hypoglycemia. So you must exclude the hypoglycemia. If the patient hypoglycemia, This may be occurs. This sudden loss of consciousness, speech loss, speech difficulties, all the things, visual loss. It may be occurs in the if it depends on the hypoglycemia also. So you must exclude the hypoglycemia. This is the important scale, Roger scale. And what is the focal sign? I told you that the definition focal deficit. This focal sign means unilateral or bilateral motor weakness, unilateral or bilateral sensory impairment, aphasia, dysphasia, anopia, diplopia, force gaze, apraxia of the acute onset, ataxia of acute onset, and perception of deficit of acute onset. What are the atypical presentation of stroke? This is dizziness, vertigo, localized headache, blurred vision of both eyes, dysarthria, impaired cognitive function, impaired consciousness, seizure, and dysphagia. If we go for the this all are if this another presentation ischemic stroke according to the types. This is thrombotic. Thrombotic occurs usually in the old age. Hypertension, prior stroke, smoking, diabetes mellitus, all are included in the thrombotic stroke. It occurs usually at rest or sleep. Sudden onset may progress minutes to hours and days. No headache, no vomiting, no altered level of consciousness. Embolic stroke, it occurs in any age. I told that this thrombotic stroke occurs in the old age, but embolic stroke occurs in any age. Source of embolus, it may be heart, it may be artery to artery or cardiac like that. And during the activity or rest, a sudden onset, no progression. It is not progressive because embolic stroke, it not progresses. And no headache, vomiting, alter level of consciousness, neurodeficit according to inflammatory vascular territory. Initially, paralyzed limb may be flaccid or reflex are decreased with extensor plantar, but later on muscle tone increases and reflex becomes the hyperactive. And focal neurological deficit occurs according to the inflammation of the vascular territory. Initially, paralyzed limb may be flaccid or reflex are decreased with extensor plantar, but later on muscle tone increases and reflex become hyperactive. What is the ICS presentation? It occurs in the middle age, uncontrolled, poorly controlled hypertension during activity and excitement, and sudden onset may progress to minutes to hours. Severe headache, vomiting, altered level of consciousness, and confusion. And subarachnoid hemorrhage, subarachnoid is less common than ischemic stroke, and intercerebral hemorrhage are affected the 6 per 100,000 of the population. Women are affected more common than men, and the condition is usually present before the age of 65 years. The immediate mortality of aneurysmal subarachnoid is 30%, and survival may be recurrence or rebleed rate about the 40% in the first weeks and 3% annually thereafter. 85% subarachnoid are caused by the saccular or berry aneurysm, arranging the bifurcation of the cerebral artery, particularly in the region of circle of Willis. Most common side of anterior communicating artery, 30%, posterior communicating or PCOM, posterior communicating artery is 25%, and middle cerebral artery 20%. What are the clinical presentation? It occurs in NES, vascular headache, uncontrolled poorly controlled hypertension during activity and excitement, sudden onset severe headache. So you all this name thunderclap headache is a very familiar name for the medical student, thunderclap headache, and vomiting, altered level of consciousness, convulsion, fundoscopy will see the subhyaloid hemorrhage, and sign of major irritation develops 3 to 12 hours after the hemorrhage. Photophobia and focal neurological deficit may be present or not, because I tell you before in the definition, focal or global. Global included in this definition due to the subarachnoid hemorrhage. What is the difference between the ischemic and hemorrhagic stroke? And it's very important. This is the acute reactive hypertension, usually common in the hemorrhagic stroke, usually uncommon in the ischemic stroke, but may be present in the ischemic stroke. And vomiting common, ischemic stroke vomiting uncommon, and headache common, seizure common, and alteration level of consciousness all are common in the hemorrhagic stroke, and ischemic stroke is usually uncommon. What is the differential diagnosis of stroke? You will find if you find is like that: structural stroke mimic and functional stroke mimic. Structural means there's any pathological structure that's affecting the brain. It may be it may be the differential diagnosis of stroke is a primary cerebral tumor, metastatic cerebral tumor, subdural hematoma, cerebral abscess, peripheral nerve lesion. This is vascular or compressive, and demyelination. And functional stroke mimics is a total paralysis that after epileptic seizure, hypoglycemia, migraines aura with or without headache, focal seizure, Meniere's disease or other vestibular disorder, conversion disorder, encephalitis. And what are the characteristic features of stroke and non-stroke syndrome? That is stroke mimic. You will heard this term stroke mimics several times in recent recent studies and recent treatment plan of stroke. What is the difference in stroke? Stroke mimics. Stroke is a symptom of sudden onset. Stroke mimic often slow onset. Symptom progression rapidly reaches the maximum severity, often gradually onset. Severity of deficit unequivocal, may be the variable uncertain. Pattern of deficit hemispheric pattern, it may be non-specific. There is a confusion, memory loss, balance disturbance. Loss of balance uncommon and more common. Then another common term is venous stroke. Venous stroke is caused by a blood clot blocking the veins that allow the blood to the brain, or allow blood to drain out the brain. Venous stroke causes a back pressure effect and leads to the stroke, because when there is venous obstruction, there is a increased pressure in the vein, and it causes the backflow to the vein, because veins come from the draining of the deoxygenated blood from the brain. So if there is venous obstruction, it backflow to the brain. So this causes the stroke. And commonly, venous stroke commonly occur in superior sagittal sinus thrombosis or lateral sinuses, and tributaries, cortical and deep veins are maybe syndrome. And they are often multifocal, bilateral, affecting the both gray and white matter and subcortical white matter. May present without focal sign. This is the superior sagittal sinus. You see the superior sinus. This is the transverse sinus. This is the inferior sagittal sinus. This is the great cerebral vein, and this is the cavernous sinus. This is jugular vein. This is the jugular vein. And causes of venous stroke is the predisposing systemic causes, the dehydration, thrombophilia, pregnancy, hypertension, basic disease, oral contraceptive use. And local causes the paranasal sinusitis, focal skin infection, and meningitis, subdural hematoma, otitis media, skull fracture, and painting head and eye wound. Venous stroke clinical feature is like that. It's a headache is more common, vomiting, tangent visual obstruction, because there is when there is a venous stroke, there is the increase in the pressure in the brain. This causes the papilledema. This is tangent visual obstruction, focal or generalized seizure, lethargy or coma, and papilledema. Clinical feature according to the site of vein involvement. There is a cavernous sinus thrombosis, proptosis, ptosis, headache is important. Suprachiasmatic stenosis, headache, papilledema, seizure is common, and transverse sinus thrombosis, hemiparesis, seizure, and papilledema common. So all the venous sinus thrombosis, severe venous thrombosis. So if you examine, you will find that headache and papilledema. Headache, vomiting, and papilledema. And how can you diagnose it? Reliable diagnostic tool is MRV, magnetic resonance venography. Magnetic resonance venography, this is MRV. If you go for the diagnosis, if you diagnose the venous thrombosis, this is the magnetic resonance venography. And treatment, reduce intracranial reduce the intracranial pressure. So we can say this mannitol is like that, and sometimes it's the steroid also. Prophylactic anticonvulsant, and because when there is a venous thrombosis, there is more chance of the seizure attack or the convulsion. So prophylactic anticonvulsant we can give it. Antibiotic most commonly in the staphylococcus areas, because infection is the important causes of venous stroke, and anticoagulant is very important. And so all the venous stroke will use the heparin followed by warfarin, because sometimes we think that hemorrhage we usually avoid the heparin on the warfarin, but if it is the venous stroke, it may be either it may be hemorrhagic or it may be ischemic, so we'll use the heparin followed by warfarin. Another term is lacunar stroke. Lacunar stroke or lacunar infarct is the most common type of stroke. It results from the occlusion of the small penetrating arteries that provide blood into the brain's deep structure. What do you mean lacunar? Lacunar means is like is a pond, a small pond surrounded by land like that. So, patients who present with the symptoms of the lacunar stroke, but who do not have yet diagnosis, not yet diagnosed, imaging performed, may be described as suffering from the lacunar stroke syndrome, LACS. So, lacunar stroke, you must go for the diagnosis of neuroimaging. Infection is followed by atherothrombotic lipohyalinotic occlusion of the small arteries in the brain, and preferred term is small vessel stroke, accounted 20% of all stroke. There is some presentation: pure motor or hemiparesis, ataxic hemiparesis, dysarthric or clumsy hand, pure sensory stroke, mixed sensory motor stroke. So some presentation is like that: pure motor, hemiparesis, some ataxic. Sometimes patient may be difficult to walk, and dysarthric or clumsy hand, pure sensory stroke, and mixed sensory motor stroke. And how can you diagnose a stroke? So I told you that before that stroke is always clinical diagnosis, and for imaging purpose or other investigation we go for the to detect the subtype of stroke, whether it is very hemorrhagic or it may be ischemic like that. So stroke diagnosis always in clinical. To confirm the type of so aim of investigation to confirm the type of vascular lesion and distinguishing cerebral infarction from the hemorrhage, and to identify the underlying vascular disease and risk factors. So, what are the investigation we done for the acute stroke? If it is vascular lesion, it must be CT or MRI. If it is ischemic hemorrhage, CT or MRI. If it is subarachnoid, it must go for the CT scan and lumbar puncture. If the any cardiac source of the bolus, it go for the echocardiography and echocardiogram. And what is the underlying vascular disease? So underlying vascular disease, we will go for the Doppler study of carotids, magnetic resonance arteriography, and CT angiography. And Doppler study, you can diagnose the carotid artery thrombosis or stenosis like that. MRA, you can go for the stenosis of the carotid vessels also in the if you go for the aneurysm, with the AVM, we can go for the MRA, and CT angiogram go for the any vascular anomaly in the brain, also in the any obstruction of the cerebral stenosis like that. And contrast angiopathy is to go for the another contrast used for during the angiography. And what are the risk factors? Full blood count, cholesterol, blood glucose. And what is there an unusual cause? ESR. So ESR is for the vasculitis like that, and vasculitis is the SLE if we go for this one, and for clotting and thrombophilia screening. What are the indication of immediate CT or MRI in acute stroke? Patient on anticoagulant or with abnormal coagulation. plan to do a thrombolysis or immediate anticoagulant, deteriorating conscious level or rapidly progressing deficit, and suspected cerebral hematoma to exclude the hydrocephalus. So, for the indication of CT or MRI, according to the your textbook, Davidson, they written here, the patient on anticoagulant or with abnormal coagulation, plan for giving the thrombolysis or immediate coagulation. You will think that, and deteriorating conscious level and rapidly progressing deficit and suspected cerebral hematoma to exclude the hydrocephalus. In here, you will see, if you go for my books, the neuroimaging clinical practice, you will find so many differentiation and so many points to diagnosis the ischemic stroke, like in the textbook. So in here, you see there is black coloration of this part of the brain. This is the this left-sided ischemic stroke. Left-sided, this artery is maybe the MCA. It's a medial cerebral artery territory, the MCA stroke. Okay? This is the MCA stroke in hypotension area in the left MCA, involving the frontal and parietal. Another, in previous slide, we see the black color. So black color is due to the ischemic stroke, and this is the white color is called hyperdense lesion in the gangliothalamic region in the left side. This is the hemorrhagic stroke. And another, you see there is a the Sylvian fissure. There is a blood in different part of the brain. This is the perimesencephalic cistern. So blood or this hyperdense lesion in the Sylvian fissure and other alveolar cistern. So this is called the subarachnoid hemorrhage. You see, this figures also you'll find in your division also. Total anterior circulation. This anterior circulation is frontal to up to the part of the is above the part of the occipital lobe. It's total anterior circulation. In the anterior circulation, this is responsible for the MCA occlusion. MCA occlusion, the anterior circulation, and partial anterior circulation. This is the part of the MC territory. It may be the M4. In the middle cerebral artery, M1, M2, M1, M2, M3, M4, M5. It's like that. So maybe this is the distal part of the middle cerebral artery. Obstruction of the distal part of the middle cerebral artery. So this is the partial anterior circulation. And you see the lacuna symptoms. The lacuna, small lesion in the like a pinhead lesion in the gangliothalamic region. It's a bit near to the thalamus. It's a small lesion. This is called the lacuna syndrome. And it's posterior circulation. Posterior circulation always the supply in the vertebral system. This is the posterior circulation stroke. This is the visual cortex and the cerebellum and the cranial nerve. It's all the posterior circulation stroke. What is the role of MRI in diagnosis? Acute ischemic. AIS means acute ischemic stroke. MRI is more sensitive in early detection of acute ischemic stroke, can detect a stroke within minutes. And CT scan sensitivity is 50% in case of acute ischemic stroke, but MRI DWI, diffusion weighted image, is sensitivity at 88 to 100%, and specificity at 86 to 100%. What is the MRI is less sensitive for acute blood product than CT, and it is more expensive, less rapidly available, and claustrophobia limited use. And DWI image and MRI is more sensitive in acute ischemic stroke. So whenever we think that there is a hemorrhagic stroke, we'll go for the CT scan. In here, you see CT scan. In here is the early change in the early change. This early change is the loss of there's a gray-white differentiation is present here, but there is less gray-white differentiation. So this is the part of the acute ischemic stroke in early stage. And you see And this is the DWI, diffusion weighted image. In here, there is a less blood supply, and ADCC, apparent deficient coefficient. Is when there is a go for the run for the diffusion weighted image, we'll go for the DWI. So this is the part of this is the white one, and in here, in according to the black one, DWI and ADCC. DWI and ADCC, you will check whenever you go to the word and in the word round. You will find whenever you find see the MRI, you will check the stroke patient. If the patient is done the MRI, you will find DWI and ADCC. Like this picture, one is black one is white one. Other investigation is the duplex study. Ultrasonography is a transcranial duplex. CT angiogram. This is CT angiogram. And MRI angiogram. This is AVM or aneurysm. You can diagnose the MRI angiogram. And this the DSA. This DSA is a digital subtract angiography. This that we can find it there is a AVM. So investigation plan in case of hemorrhagic stroke, the urgent CT scan, you can go for the urgent CT scan. CT scan, if there is the hemorrhage, is a large hemorrhage, you will find it that there is a shows the subarachnoid hemorrhage, and you will find sometimes the negative subarachnoid hemorrhage, negative in the 15% cases. Then we're going to wait for the another 12 hours and go for the CSF study. And if the CT and CSF study are negative, patient has not had subarachnoid hemorrhage. So if it is negative within earlier phase, there is a CT scan, it may be negative, and wait for the 12 hours. After 12 hours, you will go for the CSF study. If it is xanthochromic, so we will think that it's subarachnoid hemorrhage. If it is not xanthochromic, so we think that if the CT scan and CSF negative, that patient has no subarachnoid hemorrhage. Aim of treatment. Our aim of treatment is revascularize the ischemic brain by the thrombosis and salvageable ischemic penumbra. I tell you before the ischemic penumbra. Ischemic penumbra is very important for the ischemic stroke. We are the neurologists. Our target is to save the ischemic penumbra. Save the ischemic penumbra. So if the salvageable ischemic penumbra is by neuroprotection, prevent early recurrence of stroke and rehabilitate the patient. How can you manage the acute ischemic stroke? General management, specific management. General management, there is the A, B, C, D, E. That is the A for airway, B for breathing, C for circulation, D for draw blood, E for evaluation. So whenever patient comes to E with general management, you will see the A, B, C, D, E. Before that, you know the A, B, C. Airway, breathing, circulation. And we will go for the airway, breathing, circulation, draw blood, and then evaluate. Then after that evaluation. So because if the stroke patient comes to the urgent emergency room, if you don't manage the general management, then patient will go and deteriorate the patient. Because if we initially we go for the general management, then go for the after that we assess the patient. So it will be better for the a better outcome for the patient. Specific management is the anticoagulant therapy, artery canalization, and aim reperfusion ischemic zone, thrombolysis, clot removal with the mechanical thrombectomy, and antiplatelet therapy, neuroprotection and repairing therapy, and treatment of complication, prevention of stroke, and rehabilitation. So we must think that we have 5 fingers in the hand. So we must remember what is the management of acute ischemic stroke, general management, specific management, treatment of complication, prevention of stroke, and rehabilitation. So whenever you write any management, you can think in this way. So it will be you will elaborate your written section as well as your Viva section also. So any management, you can think the general management, specific management, treatment of complication, prevention, and rehabilitation. So in case of stroke, the general management stroke, specific management stroke, treatment of complication, prevention of stroke, and rehabilitation. And what are the specific treatment option of the ischemic stroke? Specific treatment option is a IV RTPI or intra-arterial RTPI. IV means intravenous, আর RTPA means হলো recombinant tissue plasminogen activator or intra-arterial tissue plasminogen activator. Then with the bridging theory, bridging means in addition to the mechanical thrombectomy. If the IV RTP is not working, then we will go for the mechanical thrombectomy. General management, I told you the before, IV, C, D, E, and and general management is should blood glucose should keep in the less than 11.1 millimole, and infection or fever if they are detrimental should be the appropriate measure. Care skin, mouth, eye, bowel, care the skin, mouth, eye, bowel, and bladder, and all the because in our country alcohol is not alcoholic addiction is not important too much. So in the Western country, all the patient present with the stroke, they must give the IV thiamine for the malnourished alcoholic patient. And maintaining blood pressure, optimize cardiac output, and maintain high normal blood pressure, and keep severe perfusion pressure approximately 8 to 10 centimeter per centimeter of water. Perfusion, ischemic zone, thrombolysis, mechanical thrombectomy, antiplatelet, neuroprotection. What is the anticoagulant therapy? CT head. We can go for the prerequisite for antiplatelet. Prothrombin time, platelet count must be done prior to anticoagulant therapy. How can you get the indication? Indication is stroke and evaluation, eccentric TIA, embolic stroke, chronic valvular heart disease, MI with mural thrombosis, mitral valve prolapse, atrial fibrillation, prosthetic valve, and venous or venous thinous thrombosis and venous infarct. So anticoagulant therapy is that we can use the heparin, low molecular heparin, warfarin, and gelmetron. And how can we the artery recalculation or thrombolysis therapy in acute ischemic stroke? That's the clinical diagnosis of stroke indication. Clinical diagnosis of stroke. Onset of symptom is drug administration less than 3 hours. In here, recently we'll go for the 4.5 hours for anticoagulation. And CT scan showing no hemorrhage or edema more than 1/3 of the MC territory, and age more than 18 years, and consent of the patient. And continuation sustained blood pressure 185 to 100 despite the treatment, platelet less than 1 lakh, hematocrit less than 25, glucose less than 50 or more than 500 or more than 400, use of heparin within 24 hours, and rapidly evolving symptoms, and gastrointestinal bleeding preceding 21 days, and coma or stupor. What are the drugs available for the IV thrombolysis as or intra-arterial thrombolysis? RTPA, recombinant tissue plasminogen activator for the IV use or intra-arterial use. This is the common. And previous time, pro-urinary streptokinase, this one using before, but now it is using the IV RTPA. Is very much used in my country also. What is the mode of action RTPA? Convert plasminogen to plasmin, the latter being the proteolytic enzyme capable of the hydrolyzing fibrin, fibrinogen, and other clotting protein into the low molecular fibrin and degradation of products. And dose 0.9 to 9 milligram per kg, 10% given the IV bolus, and rest of the given in the over 1 hour. Maximum dose is 90 milligram. And other revascularization intravenous thrombolysis RTPA is approved 3 hours. This is another study, and another study 4.5 hours. And intra-arterial thrombolysis given in the effective in the PROACT another analysis is 6 hours. So you can say intravenous thrombolysis or intra-arterial thrombolysis is usually up to the 4.5 hours is very safe for you. Prognosis following the thrombolysis, 3 months following the RTPA, neurological deficit 30% are normal, near normal, 30% mild to moderate neurological deficit, 20% moderate to severe neurological deficit, and 20% died. So if I go for the thrombolysis, so more than 60%, around 60% patient is going to be improved. So nowadays in my country, we'll practicing the IV thrombolysis or IV thrombolysis for this patient. And another is endovascular technique. Sometimes when the clot is too big, when the MCA territory clot is involving the MCA territory more than one third territory, so we'll think that we will go for the endovascular mechanical thrombectomy. So this also done in my country also. So we are the intervention intervention neurologist. So we'll go for this mechanical thrombectomy and IV thrombolysis also. And this is all done in my country. Another antiplatelet candidate, aspirin is the only antiplatelet agent has been prospectively studied treatment of the acute ischemic stroke. So if you diagnose the type of stroke, if you ischemic stroke, you must give to the patient to the antiplatelet, this aspirin. And neuroprotection, there is no role of neuroprotection in the thrombolysis, but they have tried some therapeutic. They have tried in a different way in different neuroprotective, but it is not working. NMB receptor antagonist, MK801, glutamate antagonist is not working at all. But therapeutic hypothermia is very much important for the treatment of acute ischemic stroke. If we decrease the temperature 2 to 3 degrees centigrade, so it will improve the it will decrease the metabolic activity of the brain to 20 to 30%. That causes the less damage to the brain. Then another neuro repairing agent is also used in my country, but it is not recommended. Usually not recommended. There is citicoline, IV magnesium, sodium channel blocker, levodopa, and potassium channel opener, niconadil. This not effective, not effective that yet available. What is the treatment of hemorrhagic stroke? Hemorrhagic stroke is treatment only for the evaluation how is the size of the hemorrhage. So if it is a supratentorial hemorrhage less than 30 ml, good prognosis, wait and see. And if it is the 30 to 60 ml, intermediate prognosis, and more than 60 ml, bad prognosis. So extension in the ventricular system worsen the prognosis. Intestinal hemorrhage is 50% die. For raised ICV, hyperventilation mandatory is given, and glucocorticoid is not useful. Infratentorial hemorrhage, immediate consult with the neurosurgeon. And if it is evacuation of the hematoma is beneficial in cerebral hematoma, not helpful in others. Size of hematoma more than 3 centimeter, immediate evacuation, 1 to 3 centimeter observation, and less than 1 centimeter, no need to the patient is alert, evacuation is not necessary. And subarachnoid hemorrhage, specific treatment is coiled or intravenous, coiled by the interventional neurologist. But that is, we are done the coiling for this patient also in my country, and clipped by the neurosurgeon. That also done in my country too. And medical management, managing blood pressure, preventing rebleeding prior treatment, managing vasospasm, treating hydrocephalus, treating hyponatremia, preventing pulmonary embolus, preventing rebleeding. What are the complications of stroke? And complications: chest infection, dehydration, hyponatremia, hypoxemia, and seizure. All these years, if there is chest infection, antibiotic and physiotherapy, dehydration, careful rehydration, hyponatremia, water deprivation, hypoxemia as usual cause, and seizure. If it is a seizure with stroke, then the anticonvulsant is given. Hyperglycemia, another complication, hyperglycemia, repeated on diabetes, deviance thrombosis, give the anticoagulation, frozen shoulder, give the physiotherapy, pressure sore, given the nursing care, urinary infection, antibiotics, and constipation, go for the appropriate appropriate uh, apparent. How can we prevention of stroke? The primary prevention, secondary prevention. Primary prevention take the prevent in the very first attack the stroke. Secondary prevention measure to take in the precurrent prevent of stroke. Primary prevention is lifestyle modification, medication. Medication is treatment hypertension, treatment of diabetes mellitus, antiplatelet therapy, anticoagulation therapy, antivascular intervention, and surgery. And primary prevention either is cardiac stenosis, endovascular balloon angioplasty, stenting, surgical intervention is carotid endarterectomy. What are the secondary prevention? Risk factor, assessing risk factor, antiplatelet therapy, AC inhibitor, ARB, statin for all patients. You see, there is another flow diagram from your textbook. A stroke, go for a CT scan. If it is hemorrhagic, treatment is the lower BP, and lifestyle modification is like that. And if it is ischemic stroke, and we'll think that if it is TIA or ischemic stroke. TIA always include a treatment as like that ischemic stroke. This is the ECG, it is sinus rhythm, antiplatelet. If it is atrial fibrillation, thyroid function evaluation, and echocardiography, and consider cardioversion and arrhythmia. And cardioduplex, if it is referred to more than 70% stenosis and symptomatic stenosis, then the cardiac aneurysm or cardiac stenosis. And if it is the cholesterol, if lower the cholesterol, if the total cholesterol is more than 3.5 millimole, that is 135 milligram, then the simvastatin 40 milligram is added. And warfarin, if there is a cardiac arrhythmia is present, there is a continuous use of warfarin. Rehabilitation, patient care is comprehensive stroke unit followed by the rehabilitation service, improve neurological outcome and reduce the mortality. Rehabilitation of stroke patient include the early physical, occupational and speech therapy, educating the patient and family. And another important thing is that stroke team should be included in the staff with it. This is the stroke unit. Now all the stroke unit is included in the consultant physician, and if the medicine and neurologist, especially nurses, physiotherapists, occupational therapists, speech language therapists, neurologist, dietitian, clinical psychologist, and pharmacist and social worker. And all these things we are now ending portion. Stroke is preventable disease. It is not a curable disease, but we can treat the stroke is now we can treat the patient. And primary prevention is very important, especially in developing country. And management stroke is unit by the team gives better outcome. Thrombolysis is novel invention and widely practiced management in acute ischemic stroke as well as in our country too. And endovascular intervention may become routine in near future. And thank you all for patience hearing. If there are any question, please knock in my messenger. I can give you the answer. And also you can go to my website. My website is draminur.com. D small letter R small letter aminur.com. So you go for my website also. You can find the lecture too.